So today's session is entitled Ethnic Disparities in Overall Mortality Outcomes, Translating Research to Action. And we have some great presenters with us here today. We have Sri Banerjee, Jennifer Perkins, and Vanessa D. Felice. And first of all, Dr. Sri Banerjee has served nearly 20 years in various public health areas, including global health. He's worked for the Centers for Disease Control and Prevention in areas of infectious disease. He's also worked on public health projects worldwide, so a wealth of knowledge that he's going to be sharing with us today. He's conducted award-winning research related to HIV and chronic diseases. He writes grant proposals. He does a little bit of everything. So he will be sharing information with us, as well as Jennifer Perkins, and she regrets that she cannot actually be on the call today because they're experiencing pretty serious storms in Texas where she is. And so, you know, sometimes that's one of the issues with these virtual meetings, is that it can impact our Wi-Fi abilities. So she's struggling with that today. So positive thoughts toward her, but we still want to give Dr. Jennifer Perkins some great kudos as well. She also has 20 years of experience as a public health practitioner, working with nonprofit organizations at the local and national level, as well as government health agencies. She's a certified health education specialist, a certified sexuality educator. She's also active in the American Public Health Association. She does quite a bit of work at various levels. She's even done work in public health preparedness and bioterrorism response. Her PhD in health studies, community health is from Texas Women's University. She has her MPH and her BS from Indiana University. So I'm here in Indianapolis, very familiar with Indiana University. So we are thankful for her contribution to this presentation as well. And then finally, Dr. Vanessa D. Felice, and she is a medical affairs and clinical research specialist with over 10 years of experience working with underserved and marginalized patient populations. She's a proud alumni of Howard University. She earned her medical degree from the American University of Integrative Sciences and her MPH from Walden. She's currently pursuing a PhD in public health at Walden. Her dissertation is a qualitative exploration of health disparities experienced by Black youth with type 1 diabetes. So she obviously has a wealth of knowledge to bring to this presentation as well. So we are thrilled to turn it over to those of you who will be sharing your knowledge with us. So go ahead, Sri.
Thank you, Heidi, for such a wonderful introduction. This is a really, really wonderful opportunity for all of us to present some exciting new research, some exciting techniques and frameworks that we have been working on tirelessly for years now, and so close to a decade. So this is some really important work, and so I'm really happy to, have all of you here listening to this. And I think hopefully from not only listening, but some of the discussion and dialogue that will come out of this will allow us to inform future research. So just to give you a little bit of background about how equity research was something that I was interested about 2 decades ago. Now, my background and my family actually, is from India. And at that point, there were a lot of different ethnic cleansing going on. So understanding disparities, ethnic disparities, and how unfortunately these impact and end up resulting in violent outcomes. This is where my first interest came from. But afterwards, building on that, these were some publications that I worked with colleagues in understanding cross-cultural communication, and also several book chapters. So just going into a little bit more about what we will be talking about today. the fact of the matter is, despite there being so many improvements in overall health, for the rest of the population, for the general population, when we look into grouped analyses and ethnic, racial minorities, health outcomes still tend to be poor. And in certain areas, Vanessa will be sharing with you shortly, these disparities are more distinct than others. And so, we will be exploring some of these and, more importantly, showing you specifically what types of surveillance systems can be explored and utilized for further disparities research. So this is more of the abstract, and this has been included within the program, so you can go over that more on your own time. But the specific objectives, of course, within this talk is understanding that not only that there are disparities that still persist within society, but how to understand them better through asking the right research questions. And then secondly, leading this inquiry to in the proper places. So whether it's nationally representative data sets, whether it's qualitative studies, but we'll be focusing on more quantitative approaches. And then using DEI principles, diversity, equity, inclusion principles, to translate some of this into actionable policy. Before we kind of think about these things, Vanessa, did you want to maybe pose these questions, and we can kind of see how our audience thinks about some of these issues? Maybe take
Sure.
5 minutes. Yeah.
Sure. So looking at the first dialogue box, think of a time when you had a productive conversation on diversity and public health in a class discussion, and describe what contextual factors made it possible.
So if you're thinking about diversity, like what were maybe there was some sort of pedagogical tool that you used, some sort of opening discussion maybe that you used, or maybe an anecdote, maybe a story to illustrate something, or maybe some sort of some issue maybe. For instance, an example that I can think of is using the Flint water crisis, as an example of equity, and how policy influenced health outcomes, and that children were suffering from lead poisoning within a community. So kind of discussing about the fine nuances surrounding that. That is a good example of that. So, and I think.
So we have a response. It says, I remember being in residence life training, and my peers shared real life examples of how issues had impacted them or their loved ones directly. We held a discourse on these topics to elaborate and better understand each other's perspective and lived experiences. So that's also a great example. And to Dr. Banerjee's point, a lot of times the conversations that we have with our colleagues, classmates, and peers might be triggered by current events. It could be triggered by the weather. It could be triggered by news reports of fatalities. I know 2020 was not only when we think about the pandemic, when we think about police reform as it pertains to the death of George Floyd, that opened up a lot of conversations, and the movements that came thereafter. So okay. Oh, Heidi. I think it's important that, those conversations be had, but, and it's done in a respectful platform. We don't have to agree, but it's important that everyone has an opportunity to share their experience.
Excellent. Thank you. Thank you, Vanessa. That's very important, I think, aspects to be also considering, the parameters so that it's a safe space. We have to create safe spaces. And so each individual has to feel included and respected. So yeah, again, excellent points. And I think that really answers the second question. Vanessa, did you want to see if we had some feedback from that
Sure.
one? Yeah.
So the next question is, what are the greatest challenges you have in facilitating productive conversations on diversity and public health in your class discussions?
So,
sorry, I just wanted to acknowledge Heidi's comment. Heidi says, I found it that it really helps with the conversation to set clear boundaries for our conversations because the context of the conversations can be very hard. And that's a really good point.
Yeah, absolutely. The context, again, also is everything. Certain aspects, for instance, when we're thinking about referring to communities, individuals that belong to certain communities, right? A lot of times, members of these communities have different designations, and then what people, in the rest of the population understand to be accepted, right? So at the end, a lot of times you have to defer to the particular communities to understand what is respectful to them. So perspective, context, all of these things are important considerations when we're thinking about equity, and especially when we're thinking about health outcomes related to equity.
Right.
And so.
Yeah. So Alexis says, I also make sure to say I am not an expert. We are learning together. That's a really good point. Heidi says that I found students have to feel comfortable in a sense of belonging in the classroom before they open up this type of conversation. And that's not only in the classroom, but every facet of our lives. If we feel like we belong, if we feel like that our voice is being acknowledged and respected, we're more inclined to comfortably voice our opinions.
Absolutely, yes. Feeling belonging and feeling like the professor or the instructor took an interest in your perspective. So sometimes maybe when it's when you're having an opening discussion, having, if it's in an online board, following up with the response, or in person, responding actually helps the person feel like they belong. And so but the purpose of this is to kind of translate some of these ideas that all of you came up with, wonderful ideas that work in the classroom, and then kind of think about how these things would be translating into health outcomes, right? So what we know contextually from our experiences as educators, now we can apply the same formula to understanding health disparities and translating to policy. So we can kind of now work on some of these additional definitions. And Vanessa, if you wanted to, explain health equity.
Sure. So this is a really good explanation here about health equity. So it can be, and this is adopted from the CDC. So when every person has the opportunity to realize their health potential, the highest level of health possible for that person without limits imposed by racial or structural inequities. Health equity means achieving the conditions in which all people have the opportunity to attain their highest possible level of health. So again, it's all about providing the necessary access and the opportunity to essentially be a stakeholder in your own health and be able to be more proactive as opposed to reactive when it comes to your own health.
Excellent. Yeah. And definitely extending on some of these principles of uneven power distribution, health equity, understanding that there are pre-existing uneven distributions of power, um, social determinants of health were founded. And so one of the most major efforts was done in 2010 by the Commission on Social Determinants of Health by the World Health Organization. And so it started off as a conceptual framework for action. And of course, if you look on the left, it's a pretty complicated sort of diagram. And of course, this has evolved over the years. In fact, there are multiple versions of this even. And there is a more updated version, which we'll be going over a little bit later, which goes into these facets in a different way. But if you want to look at kind of the categories that make these up. So you have the structural determinants on the left, the social determinants of health, inequities. And so these are different areas in which there are uneven power distribution. So it may be from governance, right? It may stem from governance, and from governance that creates structural inequities. And we see minorities and minority health in many countries being neglected and not being a priority. So a lot of times policies are there, sometimes oppressing, certain groups. Public policies, social policies, and even cultural and societal values. So, this is a quick comparison of definitions, and there's a lot of areas where, you can kind of think about where disparities versus inequities are different. But the main difference is that disparities are the differences in the incidence and prevalence of health. So, these conditions, these differences may be by race, they may be by, socioeconomic status. So we're going to be focusing the research here, we're going to be focusing more on these existing disparities. Now, these disparities can be considered signs or can be considered symptoms of existing inequities. So these inequities are unjust distribution of social, economic, and environmental conditions. So if you understand, oftentimes we're thinking of definitions as an island. We think of words existing on their own. But if you think of these definitions in comparison to the other, then it will make more sense. And it's really important to understand these concepts, foundational concepts, if you want to understand better about research and policy. So these are more sort of fine-tuning these definitions, understanding, what each of these mean and whatnot. So health disparities mean something different than health inequities versus health equity versus, social determinants of health. And one thing I want you to kind of focus on this slide is that social determinants of health are life-enhancing resources, So these are actually very basic needs that are being addressed. So if you think of Maslow's hierarchy of needs, if you think of that model, then the basic needs are what social determinants of health is addressing, which is why it is so important. If we want to understand disparities and inequities, it is so important to understand social determinants of health. And so in some of the subsequent slides, Vanessa will be going over that model a little bit more clearly with some analogies. But before we get to her segment, this is a final model that you can use to kind of categorize different forms of oppression and inequities. So while we're talking about and focusing on ethnicity within this presentation, it is important to note that age, sexual orientation, and many other sources of discrimination and disparities, social disparities, exist and can exist and influence health outcomes. So with that, I would like to turn it over to Vanessa, and she'll be going over the next segment.
Okay, thank you. Hi, everyone. So the next segment is really going to just talk about, statistics and defining some important terms as you develop your search strategy when you're trying to better understand health equity and health inequities. So here I did a search looking at, you can go back to that previous slide, please. So here, this slide just provides some recent CDC facts regarding mortality amongst Black babies, women, and men. And I know that in this country, we find that a lot of the glaring disparities are usually stratified by race, but it's also important to acknowledge and recognize that religious, cultural differences, as well as location, are also disparities that we need to acknowledge more and bring to the forefront so that we can appropriately address them. Next slide, please. So when you're thinking about your search strategy, and you're thinking about a topic, usually it could be triggered by a couple of different things. As I mentioned previously, current events seems to be the low-hanging fruit, especially if you have an interest in the news and you want to better understand the context as to how this one event happened. Personal experiences, if you experience some levels of inequity and discrimination, or you know someone who has, that can really be a driving force in really exploring the context surrounding that. So this slide really is it's a summary from Google Trends. And what Google Trends does is that it's able to analyze the top search queries that people have searched in Google. And so when you enter a term, for example, multicultural, equity, diversity, it shows you the trends over a certain period of time, and then it kind of subcategorizes it, and it really fleshes out exactly what the popular searches were. And what we see here is that across the nation, equity, followed by diversity, seem to be the highest number, the more popular search terms for people who maybe want to learn more about it, or are trying to research and explore more on it. Next slide, please. So this is a very important slide. I think it's a nice visual that brings those definitions that Shri presented together. So if we think about the tree, you have the roots, you have the trunk, and you have the branches. So what we see here is that social determinants of health, in order to appropriately, as with any plant, in order to appropriately bear fruit or improve the outcome of that plant, you really need to get to literally the root cause of the issue. And so I think it's important as public health scholar practitioners that we're able to delineate and identify what factors go into what category. Is it a root problem? Is it a trunk problem? Or is it a problem at the branch level? And once you're able to properly categorize and identify it, it really makes it easier to appropriately understand and educate others on your topic of interest. Next slide. So intersectionality, it's, I will say maybe in the past 5 years, we've seen intersectionality in a big way when we talk about, when we discuss gender and sexuality amongst individuals in this country. Next slide. So let's give some historical context regarding intersectionality. So it's a term that was coined in the late 80s by Dr. Kimberly William Crenshaw. And it was really the result of a Black feminism movement, and really identifying the fact that this concept that all oppression is linked. It acknowledges that everyone has their own unique experiences of discrimination and oppression, and we have to consider all those factors that can marginalize a group of people. When I was researching this topic, I found a really good example of how we can better understand and apply intersectionality. And so, for example, a Black woman may experience misogyny and racism, but she will experience misogyny differently from a white woman and racism differently from a Black man. The work towards women's rights must be intersectional. Any feminism that purely represents the experience of, for example, white, middle-class, able-bodied, heterosexual women will fail to achieve equality for all. And I think that's a really good example of, being a minority within a minority. And we have to acknowledge those advantages and disadvantages, appropriately, so that we can move forward in supporting health equity and providing resources to those marginalized subgroups. Next slide. So in tying in, again, these definitions, you have Healthy People 2030. So every 10 years, there are these goals established to address the social determinants of health. And so, I think the important thing to understand about social determinant health, or Healthy People 2030, is that these goals are really intended to create social, physical, and economical environments that promote attaining the full potential for health and well-being for all. So again, providing a level playing field for people to not only survive in this country, but also thrive in this country. So in line with this goal, Healthy People 2030 has a number of objectives related to social determinants of health. And these objectives highlight the importance of what they call upstream factors. So like, and these are things unrelated to healthcare delivery. So where someone lives, access to education, just access to natural clean resources, as Shri mentioned, the Flint water crisis. The Healthy People platform really seeks to identify those factors and challenges, or I won't say challenge, but empowers healthcare providers and public health officials at the state level to meet these goals to improve outcomes for their community. Next slide.
Thank you, Vanessa, for providing all of that wonderful foundational concepts. These concepts that Vanessa talked about now will inform the rest of the talk, and providing some concrete tools and steps on how to and strategies on how to conduct actionable DEI research. So one strategy is to kind of use, a suitable DEI related health model, find one that works for you. And I'll show you one such model, one that actually I've kind of created and provided. I'll provide the details of, and then also finding a suitable data set, right? So if you're conducting secondary data analysis, finding that right data set can be challenging. And then identify a principle, and then apply HP 2030, Healthy People 2030, and something else called Health in All Policies. So, due to the constraints of time, unfortunately, we won't be able to go through as much detail into, all of the different aspects, but I'll be able to share with you just a slight flavor of how some of this process works. And then I'll provide you with additional resources that you may be able to employ and use so that you can do your own research and actionable policy. So this is, the Social Determinants of Health Commission. I said, it went through quite a few iterations and developments. This is one such iteration. This was the Conference on Social Determinants of Health that took place in Brazil. And then, of course, this is more about the social determinants of health that we were talking about. And so these are some of these objectives that are related to, Healthy People 2030 related to social determinants of health. That's what this slide is. And so, there's quite a few of these sorts of goals, but you can see how these are organized. Not only are these goals present, but they also have afterwards the trend. So if there has been no change that has taken place, then that will show up, kind of at the end right here. So if you underline, so I'm underlining how these trends work. So let me clear these first. And then, so these are examples. Remember I said that you need to have a model in mind. So social determinants of health is a good model for doing research, a DEI research. And then finding suitable secondary nationally representative data sets. National Health and Nutrition Examination Survey. I'll give you concrete examples of how that can be used and harnessed for, some DEI research. Behavioral risk factor surveillance system, that's another good one. NSDUH and NHIS. Those are others that are readily accessible. If you wanted to, you can, right after the webinar, go and download these data sets. And seriously, I encourage you to go through the code book actually and take a look at some of these variables that are present that I'll be going over within the talk. So this here is something called the PRISM framework, and it's known as the Principles of Systematic Effect Modification. For the epidemiologists and biostatisticians out there, you probably have heard of effect modification before. And so while the idea of effect modification is not new, it's something that has been utilized in the past. This way of organizing research, equity-related research, is new. And so the acronym PRISM is also has been used on purpose so that the acronym evokes the idea of a prism, which kind of systematically divides light into different colors of the spectrum. So similar to a prism, how a prism behaves, this is intended to do so. And so there's actually on a separate website, I've housed the details of this model, providing how to use it, and also there's a Creative Commons license on this. So you're able to expand on this work if you feel. And so this will kind of go through these. And so the top of this model, the PRISM model, is a factor. So here is a social factor: race, ethnicity. It could be sexual orientation here, so social factor. And then the next is some sort of maybe disease condition in this case. So in our situation, our example, we're seeing cardiovascular disease. And then the third part of this is the health outcome, which is all-cause mortality. So that could be honestly, it doesn't have to be all-cause mortality. It could be cardiovascular mortality, cancer-related mortality. There's all sorts of outcomes that you can think of. So these are not by any means, intended to be just these three. You can replace these with anything else that has been indicated within the orange category. And there's examples of research, primary original research, which have been presented in different conferences and published in different places in these areas. And these are all, believe it or not, these are all actually from National Health and Nutrition Examination Survey. And so this is a continuously collected, robust surveillance system which is collected by the National Center for Health Statistics and has a lot of variables. And I'm about to share with you some of the findings. So this is hepatitis B. This was presented in the International Hepatitis B Virus Conference. And as you can see, we created this moving GIF, moving GIF on the right to show how this works. Movement is always important. It keeps the audience's attention a lot more. But the findings that we were able to come up with from Haynes was the fact that individuals of African American descent who have chronic hepatitis B have higher 10-year mortality rates than Caucasians with chronic hepatitis B. So this is not that they have been, persistently sick from the virus, but as you know, hepatitis B it lives dormantly within the body, and so from time to time there are flares. So the question is, why are there disparities, right? So this is where more research and interest needs to be done, and so similar findings can be seen in environmental health, like BPA, and all sorts of findings. So, even cognitive function, dementia, hypertension, cancer-related disparities, rheumatology, and this is going to be presented. Gender disparities, sexual orientation disparities. So these are all these findings, and these are all included within the slides. And unfortunately, due to time, we're not, going to be able to go through all of that. If you, also think about understanding implicit bias, if we think about the reasons, why are there disparities? I went over hepatitis B health outcomes, cardiovascular mortality outcomes. There's disparities between African Americans and Caucasians. And in many different areas. So maybe there's implicit bias that we're not considering. And studies have shown that physicians have, in many situations, implicit bias, which they're not even aware of. And so this is a really wonderful short test, which I encourage each and every one of you to take. If you look up implicit bias, implicit association test, IAT, then you can find that test. And it's really interesting what you find. When I had my findings, they compare to the general population. It's really interesting. And this is how your findings will look. So these are some Healthy People 2030 trend discussions. These are some adjustments that have been made at the policy level on recommendations regarding screening. So we're making progress with policy, but there's other sorts of suggestions here where you can provide policy changes. And so these are windows of opportunity. If you study these diagrams, and if you look for problems and politics and policies, and when they start aligning, these create windows of opportunity. So look for those. And seizing those windows of opportunity are very important. There's a lot written by Lepo et al. About this. Health in all policies is also another important area. This is the historical development of this. And, I really encourage you to look into the importance of this, and understand that this is a multi-sectoral effort. When we're wanting policy change, this has to, of course, begin bottom up, ground up, but also has to, at the researcher level, we have to make sure that we're not just sitting behind ivory towers, sitting in ivory towers, producing research and not ever getting to policy. And so this is an opportunity. This is a window. This presentation is a window for you to take real action. And so, if you take the health and policy route, you can do that. If you take the social determinants of health route, I proposed a new model, the PRISM. All of those. So this is a framework, establish the need first, understand the needs, frame planned action, identify supportive structures and processes. So now that you've identified that there's disparities in hepatitis B, what are some supportive structures that you can have to try to alleviate some of these poor prognosis that minority populations experience? So this is kind of what is over here. And so, Vanessa, if you wanted to kind of go over our concluding slide.
Sure. So in summary, we know that actionable research requires creating a plan with an end in sight, since the final goal is ultimately policy. The social determinants of health is a suitable framework for not only starting but completing equity research. Secondary data sets can be analyzed using effect modification to establish racial inequities regarding various systems. And then finally, the health and all policy is a robust approach to convert research to policy within the application of policy windows of opportunity. One thing that I wanted to mention, sometimes it's kind of daunting on where to start in your health equity research. And so I think for me, based upon my clinical and research experience and just reading, staying abreast, on the latest peer review publications regarding my topic of interest for my dissertation, which is type 1 diabetes in Black teenagers, I kind of worked backwards, right? I read the literature, kind of identified the sources within the literature, looked at their references, read those references. And so, and then from there, I was able to identify the model that best suited my interests and feasibility in order for me to work on my dissertation. So there's a variety of different ways of doing it. But at least, with this presentation, you have a solid foundation as to where to start.
And so those are all excellent points. And I think that is a really good place, for us to kind of bring it all together and conclude. There was a lot of concepts, a barrage of information that we went through. By no means was this intended to be kind of, an easy talk, but I hope you've taken away some key tools that you can use and apply within your research with the end in mind, with policy in mind, with action in mind. Thank you for listening.
I think this was very good for those of us who, are active in our advocacy efforts to really implement some of the strategies that they were just talking about, thinking about, as we're conducting our own research and working in these areas, thinking about that in mind so that we have more data to support our important advocacy efforts. So very well done. We do have just a couple minutes for questions. If anybody would like to put one in the chat, we'd be happy to pose those for our speakers. We have a very short period of time, but it was such great information.
Thank you. This was a very much a joint and collective effort. I can, I can't take credit for all of the ideas that was within these slides. I don't think none of us, actually none of us can, because this is just a continuum. We're a piece of this puzzle. This kind of this monumental undertaking that we are a part of. So we're just a small piece of that.
I think one thing I wanted to just mention is that, and this is a learning lesson for myself too, but I think also as citizens, as public health advocates, we need to understand the importance of us voting, not only at the presidential level, but at the local level. Voting for people or candidates that align with your health interests of your community is really important, because they're representing your community. We see what's going on politically, and we see that there's a stalemate with every initiative that is pertaining to health equity or equity overall. We see there's a stalemate. And so it's really important that we as individuals are educated about who our candidates are, who our politicians are at the local level, because that really is what's going to help to drive the change from, again, root to branch.
You're absolutely right, Vanessa. We cannot forget about the local level. Some people will say all politics are local. We certainly, we need to work at every level, but we cannot forget that local level. It is a key. This does bring us to the end of this session. Thank you so much to our wonderful presenters, Shri and Vanessa. And we're sorry that Jennifer couldn't be with us today, but please give her our best. To those of you who are seeking continuing education, the recording and evaluation will be made available within 48 hours. Once complete, your continuing education certificates are available to download, and we appreciate you joining us. We hope that you will exit this and then join the next concurrent session, which is concurrent session C. And just as we close out, I wanted to say good luck, Vanessa, in finishing up that doctoral degree. So you can do